I would like to welcome you all and good morning. And let's just take a deep breath and kind of go around our shoulders. We've got to think about what we're going to talk about. I'm really excited today to be here to kick off this local playbook event. It's good to see a lot of familiar faces, although I haven't been able to see all the new people that got on a little bit ago. With the expertise and the experience and definitely the passion that's in this room, I know that this will be a very productive working session that will move us forward in implementing the master plan in aging. So we're lucky to have Debbie Toth for all that she does. She's our senior services superhero. And she works to make sure that all of our older residents in their communities, especially when she's doing her work with the governor's master plan in aging, she is the champion in here. And I'm really thanking the Contra Costa County Council for Aging and Choice in Aging for hosting this event and putting together a powerhouse team of presenters. I know that you have a lot of work to do and didn't come to just listen to another person that is elected to talk. But I want to promise you that I would be brief because Debbie asked me to be. But together we can identify the things that we can do better or new things that we can do to improve the lives of seniors. So I'm ready to do my part. And I'm now going to turn the mic over to Ms. Debbie Toth, who doesn't need an introduction, but she is the Executive Director of Choice in Aging, a member of the Governor's Master Plan for Aging Stakeholder Advisory Committee. And thank you for this opportunity to spend a little bit of time with you all.
Well, thank you, Supervisor Burgess, Chair of the Board. While I still have you on the horn, I just want to ask you, so what is your level of commitment to the master plan in Contra Costa County?
You are such an opportunist, and that's why I love you so much. You know what? I believe in you, Debbie, and I believe you're going to bring us some things that are doable, things that are needed, and so I will commit myself to you.
Okay, it's recorded and you all heard it here.
But it's got to be something I can do. You know, it's got to be something we can do.
We have amazing people that will help you do it. Yes, absolutely. So for those of you who don't know, Supervisor Diane Burgess, who is the chair of the Board of Supervisors this year, grew up in a family where her mother was working in skilled nursing and Diane was exposed and part of activities and engaging with older adults. And she just so gets it. We couldn't be more lucky to have her leading the charge right now as we venture into our planning efforts and implementation efforts. So something important for us is that it's not just a plan. It's a body of work that is iterative and that we need to implement. And I want to thank Supervisor Burgess for welcoming us, and also she is a champion, the first Board of Supervisors to really champion nonprofit organizations and building our infrastructure and recognizing the value of nonprofits out loud as a priority in her chairship of the board. So thank you. So hello, everyone. I'm super excited to be here. I'm a little nervous and a little giddy. Over 100 people who are coming together to shape the way that we age better in Contra Costa County so that people with disabilities and elders can all age in their setting of choice, which is exciting. I'm going to walk you through our program today and then make a specific ask of you. So I want to first just kind of point out that we just had the chair of the Board of Supervisors commit to helping us work and implement this master plan. It's a state blueprint, but we are crafting it with a local flavor, and it starts with that kind of commitment. It needs to be that our policy, the folks who can make policy happen in our community are on board with us, and they are. And if I ever stop talking, you're in for the most amazing presentation by my Shiro and New York Times bestselling author, geriatrician, and UCSF professor, Dr. Louise Aronson. Also, like, speaker circuit series, amazing woman. She's everywhere. Follow her on Twitter. You will be amazed. And she's also a Pulitzer Prize finalist for her book Elderhood. And if you haven't read it, be prepared to have your mind absolutely blown just in the first few pages. It paints the picture of a system gone wrong for our elders. And she will talk to us today about that brokenness and how ageism has led us to where we are today, and really provide the exclamation point for the work that we're working on now. Directly following Dr. Aronson is Jody Reed, the Executive Director of California Alliance for Retired Americans and a fellow Stakeholder Advisory Committee member of the Master Plan for Aging. And I loved working alongside Jody because I always knew I had a kindred spirit in the room who wasn't afraid to elevate truth, no matter who else was in the room, or Zoom room as it became in the course of our work. Jody's going to walk us through the master plan and take us through each of the 5 bold goals and what all is included under each, because it's one bold goal and then there's like a bunch of subcategories under each one of those bold goals. Pay close attention because you're going to be selecting which breakout session to go to based on her description and what you learn in her presentation. Immediately following Jody's presentation, you will select your breakout session and get to work. Your breakout session will be facilitated by a local expert and at least one of the team that developed the initial body of work that shaped the final master plan for aging. Your job, should you choose to accept it, is to come up with 3 topics within your goal area that should be worked on in the coming year. This means we will have 15 priority areas identified based on local need and your voice. We will then, after those breakout sessions, join back together and hear brief comments by our Congressman Mark DeSaulnier, followed by the report outs from each of the 5 breakout sessions. So I know you guys are all anxious to go to every single session and you can't. So we're going to hear what happened in those sessions. And if you aren't hearing an area that you think needs some focus, please add your ideas to chat, because we then hear from Anna Bactus, our Area Agency on Aging Program Director, about what other priorities didn't make the top 15, but deserve to be elevated and be a part of this work. I just want to ground us in knowledge that this is a 10-year plan. This is just the beginning. And remember, we are collecting all of your brilliant ideas in chat, so please chat away. Finally, we will map the 15 priority areas to the Advisory Council on Aging work groups, where this work will live and be ongoing. People who are not members of the Advisory Council on Aging are not only welcome to participate and become members of the work groups, but are strongly encouraged to do so. Our plan is only as good as the voice that you bring to it. And just a few housekeeping items before I hand off the mic. We recommend that you watch an active speaker, which you can select in the upper right corner of your screen where the cluster of white boxes are. Please remember to keep your audio muted at all times to avoid background noise. Please use chat to share ideas throughout the event. We're collecting those. Also of note, we will be throwing some polls your way. They'll pop up on the screen. Oh, look at that. There's one right there. They'll pop up on your screen. You just select the one that is you, and you can click on end the polling thing, and then boom, the poll screen goes away. Closed captioning is available by selecting the CC icon at the bottom of your screen. And that concludes the in-flight safety instructions. And now for the meat. Without further ado, my Shiro, Dr. Aronson.
So thank you for having me. A shout out to one of my Shiros, Jenny Chin Hansen, who is also here. It's been a guiding light for me throughout my career. To get started, I think if we've learned anything this year, it's that age matters. This is data from last week from the COVID pandemic, with about 80% of deaths happening in people 65 and over. And I think it's really important to emphasize that this was only in part due to biology. It had a lot to do with policies and priorities as well, just as the equally astonishing racial disparities in COVID illness and death had to do with policies and priorities and structures in our country. For example, this shows how age isn't everything. This is COVID mortality differences for ages 75 to 84 compared to non-Hispanic whites, a rate difference of nearly 900 for Black Americans. of over 500 for Latinx Americans, of 200 for Native Americans, and of 150 for Asian Americans. This is not biology. This is society and policies. Does age matter? Sure. I mean, here's COVID data, but you know, as we get older, our risk of dying goes up. And some people will use this chart on the right to say, hey, you know, old people die. We have abundant evidence that yes, old people die, and yes, we contributed to killing them with structures that we can use. We can use this pandemic as an opportunity to restructure services for older people and hopefully our healthcare system to do a better job, to show equity by race and age both. It's funny that we devalue old people at this moment in American history because our president is 78 and the head of the House of Representatives is 81 and the head of the Senate is 70 and the most famous doctor in America is 80. So we simultaneously send messages that all old people are in nursing homes while looking at evidence to the contrary. So ageism. Ageism is a term that was coined by a physician called Robert Butler. He was the one to establish the National Institutes on Aging, as well as the first department of geriatrics in this country. He was a psychiatrist, and he actually won the Pulitzer Prize for his book, Why Survive? About aging in America, which I think is tragic for how apt it still is, and yet we are making huge progress. I really do believe we are the transformation generations. So he said ageism is a process of systematic stereotyping or discrimination against people because they are old, just as racism and sexism accomplish with skin color and gender. Ageism allows the younger generations to see older people as different than themselves. Thus, they subtly cease to identify with their elders as human beings. It's that human beings thing, that you can be old and still be human, that is so often missing. For example, this headline from Time magazine, "The Road to Recovery: How Targeted Lockdowns for Seniors Can Help the US Reopen." It seems to me ironic that the initials for our country could be read also as us. This headline essentially pits us, those who count, against seniors, those who don't and can be locked down. Now, admittedly, we have locked up other people. We locked up Japanese Americans in World War II. We have locked up Latinx families and children more recently. But it's rare to see a headline proclaiming this as the right solution for the common good. This also is shown in this tweet by a person called Bethany Mandel, who starts with, "You can call me a grandma killer." Yes, we see all sorts of hateful speech, but often it gets amplified, sometimes in negative ways, but it gets edited out. This one did not. And the irony here is that there's a picture of her with one of her children. So she is what my colleague Joanne Lynn would call a grandmother in training. And yet it's so inconceivable for her to be old. It's such not a part of her life that she thinks it's fine to kill grandmas. And then this from an ethicist, which ironically was published on the day of George Floyd's funeral, asking whether age discrimination was acceptable, and actually arguing that it was. The consequences of this we saw in California, with the governor early on threatening to cut home services, figuring, well, people can't go in anyway because of the risk, totally missing the point that people went into older people's homes because of their risk, and so they needed help. And consequently, they would be forced into nursing homes, which at this point in the pandemic history were already hotbeds of COVID and yet had been given no support for either testing or PPE. As we see here, this is a California headline, so we did better than some states, but testing slow to come to nursing homes despite 35% of COVID deaths. And as you can see, this is May, so several months in. And then the federal government, in its wisdom, decided that quite literally, the deaths of old people in nursing homes before May did not count. Part of how this happens is some of the metaphors we use for aging, including this notion of the silver tsunami. I mean, it's kind of witty, you have to admit, right? Silver tsunami, and yet, what does it lead people to imagine? Things like what you see in this cartoon, which is that all old people, and for some of us, I think it's worth noting that for many people, old age starts at 60 or 65. So this is a huge number of people. Where people of that age are apparently all the same, and they are pitted against everyone else in society and will only do harm. There is no upside to a tsunami. It takes lives, it destroys civilizations, and particularly it seems bad for children, as if we don't have abundant data showing that a society in which children are healthy leads to better old age and vice versa. And having images like that makes it okay for people to say things like boomer remover. And to beat up Asians, this is just a partial listing that I saw the other day of older Asian Americans being attacked. This is one of the ways in which racism and ageism have joined hands during this pandemic. A quote here from the Ontario Human Rights Commission, which actually I happened upon by chance, but it's quite eloquent about ageism. And they describe it here as a tendency to structure society based on an assumption that everyone is young, thereby failing to respond appropriately to the real needs of older persons. For example, door handles that require more dexterity than most of us, particularly postmenopausal females, have as we age because arthritis is ubiquitous. So everything should have the handle like the one on the right. And I actually sort of loved in pandemic how my elbow could open that and keep my hand clean. So it has many benefits for many people. We build bathrooms that are ageist in a number of ways when we might build bathrooms that were more age-friendly. Interestingly, an age-friendly bathroom is friendly to people of all ages, whereas an age-unfriendly bathroom is not. So it's not friendly to older people and people with disabilities. But imagine too a person with a sprained ankle or a broken wrist, a child, a person who is pregnant, a person with disability who isn't old, the numbers of people who would be helped. And it also, how people with disability and old people were seen in society was evident from just how ugly these things were. They're getting prettier. I will admit that online you only find what looks like incredibly expensive bathrooms, but there are more attractive options for all of us at this point. Similarly, we build parks and public spaces and public buildings with thoughts of children and adults, but not with thoughts of elders. This is getting better. I know in Contra Costa, many parks now have pickleball courts. I would also argue that we could use that same material that lowers the chances of fractures that they put under jungle gyms. We could put those onto Tai Chi courts. Tai Chi is the exercise intervention most known to prevent falls and fractures, which are the number 5 leading cause of death among older people and a cause of incredible morbidity, not just fractures and head trauma, but also a fear of falling, which leads to, constriction of life, constant anxiety, loss of social life, loss of physical function. Age-friendly communities, so important. I know you're going to spend much of today on it. I just like to emphasize all the different parts. I also want to respectively disagree that community support and health service, I think when you lump those two together, or civic participation and employment, you do an injustice to each of them. I personally look at this list and I see 11 items in need of attention. We also learned a lot about how if you make it worthwhile for older people, they can adopt new technologies. Oh, surprise, surprise, right? You may not know that the first iPhones were made to fit in the back pocket of a young male, the very people who designed the iPhones. And after they were in all over the place, they realized women weren't buying them in as large numbers because actually we don't put our phones in our back jeans pockets most of the time. So similarly, we have made tech for younger people and then said older people didn't use it because they were stuck in their ways, not because we didn't make it useful for them or designed some of it with them in mind. But with all the incentives of pandemic, it turns out people will use it if they can afford the device and if they can access broadband. Here we see more definitions of ageism from Robert Butler: prejudicial attitudes towards older people, old age, and the aging process. We hear the language of implicit age bias constantly. 94 years old and still sharp as a tack, which is the same as saying most 94-year-old people are not sharp, they're dumb, which actually isn't true. Yes, rates of dementia go up with age, but communicating slightly more slowly as a 94-year-old might has nothing to do with their intelligence. And even if they had dementia, that would have nothing to do with their value as a human being. She has a young spirit or a young heart. So here, young means good spirit or good heart. When we equate young and good, we have a real problem as we get older, as all of us hope to do, right? He looks younger every day, meaning he's looking well. Why not just say that? Internalized ageism is a huge scourge, partly because we've all grown up in the age of, in a culture of implicit bias, and we take this into ourselves. I've seen this so many times I can't even say, speaking at old age communities. The one on the left, 76 years old, and when asked if she considers herself to be old, she says nope, and then continues to refer to the other residents as old people. And the people who feel uncomfortable using the term for their life stage: I'm not old, I'm just more mature. Health is for the young. When you're our age, you do the best you can. Of course, health looks different at 20 and 50 and 80, but health is not just for the young. You're less likely to be healthy, though, if you hold to this perspective. Indeed, you're more likely to die years earlier. There are so many books about old age that reinforce prejudice against self and prejudice against others. Age doesn't matter unless you're a cheese. I have to say, by my 40s, I knew this to be a lie. Old age is always 15 years older than I am. I mean, okay, so they're funny. It's definitely funny. And, you know, we all sometimes feel this way, and at the same time, it's doing harm. Then there are these: how not to become a little old lady. We get shorter as we get older. So how not to become a little old lady is to die young. That really doesn't seem like a good option, unless, of course, we're equating little old lady with a person of no value, which is inaccurate and harmful. And how not to become a crotchety old man. The crotchetiness, I believe, has to do with not having opportunities and not having good medical care to make you comfortable in your own body. It's not something that inherently comes with old age. We end up with things like this happening. Talk to me, not my daughter. I mean, I think people with disabilities are also used to this, being talked over and around when you're right there and perfectly capable of speaking for yourself. And internalized ageism absolutely kills. For those who don't like graphs, I apologize. I will narrate what these show. The one on the left shows that people with negative images of aging have their first heart attack or stroke 7.5 years before people who feel more positively about aging. This probably has to do with two things. One is, if you believe that aging is worth living, then you're going to take better care of your health. The other thing is that prejudices, and we have an abundant data on this, and race lead to a sort of constant fight or flight response, a constant secretion of this hormone called cortisol, which leads to inflammation and disease. So it literally kills you to have these attitudes. You recover less well, you live less long. Again, Bob Butler, his second example is discriminatory practices against older people. We certainly see this all the time in medical training. Everyone learns how to deliver babies, though fewer than 3% of it ever do that after medical school. We all learn about children, though a small minority of physicians treat children. We do not learn about older adults, although they are disproportionately represented in health services. And the NIH put policies in place in the 80s for non-discrimination in research against people of color and women. Now, admittedly, that didn't go as well as it should, but at least they had the policy. And against discrimination against children in the 1990s, they did not institute similar mandates to include older people when the results of the trial would affect older people until 2019. That is blatant ageism. This from the flu. One is from Stat News, which is a big reporter of health news started by a group from the Boston Globe. So this is flu, but literally, so they talk about, it's from a couple years ago, but this happens all the time. Last week, the CDC reported that 4 more children have died from flu this season, bringing the number of pediatric deaths to 11. Now, of course, it just feels so wrong for a child to die, and I'm not advocating for child death here. What I'm saying is that at this point, when 11 children had died, well over 10,000 older adults had died, and they don't even warrant mention. Part of that is for reasons that people use to justify their ageism. This from the San Francisco Chronicle. Though people 65 and older are the most vulnerable to flu, reporting their deaths is problematic for 2 reasons. It would require too much time and money. God forbid we should use any time and money on old people. And their cases are often complicated by multiple health problems that make pinning a death from the flu challenging. I would argue that if you have multiple health problems and you're feeling just fine and functioning well in your life, and you get the flu and you die, even if the flu made your heart failure worse or made you delirious from your dementia, the flu was the primary cause of your death, and it's not actually that hard to count it if you have comfort with complexity. And until we have comfort with complexity, we will never deal with income, race, or age the way we need to have equal opportunities and good health care in our society. This plays out in all kinds of ways, including on the CDC website. This is the list of things we all need to look at, regardless of who we are, and note how it's sort of speaking to adults. We know this because there's a pullout section for children and teens, right? And the pullout section has 9 different subcategories. So terrific. We're actually dividing people by age because we recognize that social and medical needs differ by age groups. Except for here's this pandemic where 80% of deaths are old people, and I'm looking and I am not seeing old people. Oh, but if you look under people at increased risk, you do get 1 page on older adults. 1 page. That was true through April of 2021, so for over a year of pandemic. And then they improved it with this, where now there's 1 page for older adults. There's a page for caregivers of people living with dementia. There's a page for people with disabilities that doesn't really distinguish whether you aged with your disability or you aged into disability. And there's a separate page for nursing homes and long-term care. But basically, they are taking a very different approach to old people than the approach they are taking to children and adults. We see this also in the vaccine schedule. How we decide how to vaccinate people has to do with the function of immune systems, biology, and social behaviors. So for children, you're not meant to read this, by the way. I realize that's impossible. You're meant to note that there are 17 subcategories because children change a lot in the first 18 years of life. And here's what we get for adults. There are 3 categories for adults and a single category for elders, as if 65 equals 85 equals 105. And even a 5-year-old couldn't tell the difference between those people. We basically have a double standard for old age, and that standard is lesser, as it so often is for people from all sorts of groups. And Bob Butler's 3rd point is that institutional practices and policies that perpetuate stereotypes about older people are ageist. So this is from Boston's anti-ageism campaign, and I pick on them a lot, I'm sorry to report, but this is a stunningly gorgeous woman, age 86, and she says she's a lot of things, but over the hill isn't one of them. Well, technically, and this is both my biologist, where I think of a bell curve, shaped like this, and my writerly thing, where I think of a narrative arc shaped like this. So the midpoint is about halfway, and most hills and mountains are that way too. It's about halfway, which means that, let's say she looks in great shape. She's going to live to 100. So if she's going to live to 100, the midpoint was age 50, so she's been over the hill for 36 years now. I personally am not going to live to 100. I feel certain of that already. So I've been over the hill for many years too. Do all of our lives have no value over the hill? Wouldn't it be better to think about how we recognize the values of the second half of life rather than denying it? Yes, over the hill connotes for many people being out of touch and out of date. But technically, that's actually not what's going on. Similarly, this from the same campaign, an older man saying he's a longtime boxer and he's not frail. Well, with my geriatrician eyes, I think he's going to be frail pretty soon. If he gets COVID, he'll be frail almost instantly if he has a stroke. And if not, from the bend of his spine, from how he looks, it's just a matter of time. Rather than having a society in which we tell people not all old people are frail, basically othering the unwell or disabled old, trying to benefit the able and higher functioning old at the expense of the others. Would it be better to have a society in which the hope was we would all live long enough to live to the stage of life at which we are frail, and that when we got there, our life would still feel worth living to us and those around us? That seems a far better message to me. In my own profession, we are often part of this problem. The word geriatrics was coined to be an analog to pediatrics, and yet we tend to focus on the oldest and sickest of old. At UCSF, we have just changed our aging clinic to be, at first it went from everybody 65 and up, then it was 70, then it was 75, and then it was 80. It's because we can't meet the need. But meanwhile, it sends the impression that old age is what happens to you at the very end. It's sort of like saying adolescence equals childhood. This is decidedly not true. It's important to think about the things that are unique to frail elders. But as COVID showed, our bodies change in middle age in significant ways. And by even a healthy elderhood in our 60s, care that understands that phase of life and the biological and immunological differences of older bodies is essential. And yet, the American Geriatric Society has about 6,000 members, but this American Academy of Anti-Aging Medicine has 26,000. Note anti-aging. It's sort of like being anti-human. Biologically, we begin aging in utero. It's better, more comfortable for me to say anti-racism or against the thing that is against the human being. Here we are blatantly against the human being, counterproductive. We see how this plays out in medicine. There is this tremendous effort to make age-friendly health systems. It is transformational. It is wonderful. It is helping everywhere, mostly inpatient, moving to outpatient, thinking about what life stage people are at, how long they're going to live, what matters to them, what medical care they want and don't want, medicines and the harms of medicines, keeping the brain functioning, keeping the person able to walk. And yet, what do we get for children? We get fancy new hospitals with artwork that costs more than the entire budget for geriatrics at my institution. Again, from the Ontario Human Rights Campaign, from a human rights perspective, there is a lack of sense of moral opprobrium linked to age discrimination, which in comparable circumstances would generate outrage if the ground of discrimination were, say, race, sex, or disability. And this, of course, doesn't count that you could be an older Black woman with a long-standing disability, for example. That our government is part of this was shown in Pandemic. This is an article from New York Magazine with the haunting line, "The virus is an official killer, but it had its accomplices, including the governors of New York and New Jersey, who sent sick older people with COVID out of hospitals where they could get the care they needed into nursing homes, which they had not, where they had not yet provided PPE or testing, and which were totally unprepared to have sick people separate from well people. It made people sick." My own institution, I like to pick on the home team. It seems better than picking on others. We welcome all races, religions, countries of origin, sexual orientations, genders, ethnicities, and abilities, but we're not so big on age. I feel of two minds for this. There are so ageist they didn't notice this, and also this is an accurate representation of the institutional stance. This plays out in so many ways. This is probably too much detail for all of you, but pediatrics was only founded 12 years before geriatrics in this country. Kids are 23% of the US population, elders 17, although in cities like San Francisco, it's 23%. About 2,000 hospitalizations per 100,000 people for kids, 26,000 for older adults. But there are about 70,000 registered pediatricians. There's actually more than this, but as I said earlier, fewer than 6,000 geriatricians. It's really tragic, and it shows that we're just not adapting to the current population. Now, some people will say, oh, older people use up too much of the healthcare dollar. Well, kids use up an even more disproportional percent of the education dollar, and adults use up an even higher percentage of the housing dollars and military dollars, but we don't blame them for their stage appropriate needs. So what might anti-ageism look like? These are quotes from Ursula Le Guin, who died a couple of years ago, but she says, to tell me my old age doesn't exist is to tell me I don't exist. And then she has this great comment, which is, if I'm 90 and believe I'm 45, I've headed for a very bad time trying to get out of the bathtub. Age absolutely matters. And yet age isn't everything. To think about the intersectionality, people who treat other people as less than human must not be surprised when the bread they have cast on the waters comes floating back to them poisoned. This from James Baldwin. When we Google the human lifespan, we get this. It shows 4 categories for kids and 4 for adults. I would say in my late 50s, I'm in the second to last category here, have my glasses, but my mother, 30 years my senior, is not yet in a wheelchair. So wouldn't it be better to give a more accurate picture of what old age is, and to have services be as diverse as they are already for children and adults? In medicine, I think it would look like this. It's aspirational, but hopefully one day we'll see that. So I'm going to close by just showing you this picture from the San Francisco anti-ageism campaign, which I love, showing the older people at the level of the eyes and their younger selves above and below, reminding all of us that in every adult is an elder in training, and in every elder is an adult who matters. And I thank you for your time and attention.
I'm sorry, I said I wasn't going to pop in between speakers, but oh my God, can you not help but love this woman? I just, she is such an absolute treasure in our community and speaks so clearly to what all of our hearts feel and think. So I'm sorry, I'm totally deviating from the script, and thank you, Dr. Louise Aronson, for not just coming today and educating all of us in this room and living in perpetuity on a video that we will post on our website, but for the work that you do every single day to bust ageism and bring care and love and support to all members of our aging community. So thank you, thank you, thank you.
My pleasure. And same back at you. I mean, you're making this happen.
Yeah, we're all making this happen. Thank you. And next up, Jody Reed, my co-conspirator.
Thank you for having me. And oh my gosh, I'm sort of speechless. That was a hard act to follow, Dr. Aronson. And I am so thankful that you were able to join us today. And I have to say, it's, I feel enlightened, but slightly depressed by seeing all those statistics, but we're here to change that. And so unlike Dr. Aronson, I'm not so good at patting my head and rubbing my stomach at the same time. So the staff is going to help me go through these slides. So I'll just be saying next one is time to change. For those who don't know, I am the director of the California Alliance for Retired Americans, which is a statewide grassroots senior advocacy organization. We are an organization of organizations that we have about 300 affiliated organizations, from senior centers, senior housing, resident associations, mobile home communities, union retiree organizations, all kinds of groups all over the state who have come together to speak out on their own behalf on issues that are important to them, and with a goal of helping to build a California that respects age and diversity and ability and builds towards a quality of life that we all want to envision for ourselves. We represent close to 1 million folks in California now and have chapters. And I noticed as I was scrolling through the participant list that many of our members in Contra Costa County are on this, and I'm really thankful for that, as well as many of our stakeholder advisory committee colleagues who have joined us. So there's a lot of familiar, friendly faces in this. We are part of a national network of state affiliates. We're all separate and separately incorporated and kind of do our work a little bit differently, but we come together on national issues like improving and expanding and Medicare and Medicaid and Social Security and the Older Adults Act, et cetera. So that's just a little brief who we are. Let's get into the Master Plan on Aging, which is what I'm supposed to be talking about right now. Just as a reminder, the Master Plan on Aging was created through an executive order by the governor in June of 2019 that called for the Secretary of the Health and Human Services Agency to convene a cabinet level work group of cabinet folks in the administration, but also a stakeholder advisory committee that had 30, I forget how many people, I think it was 30 some folks from all different types of organizations and backgrounds. There were academics, policy wonks, service providers, advocates, all together to try and come up with this 10-year roadmap, if you will, on how we can build a more friendly environment as we all age. And I think Dr. Aronson said it really well. We start aging from the moment that we're born. And so this is really about a lifespan plan, not about something that's for one particular group only, but it's a lot of the recommendations and a lot of the work I hope you do later really looks at how do we build a better network of supports and services so that we all age from wherever, from birth, as my assembly member used to say, from sperm to worm or cradle to grave or whatever you say, that it's a lifespan and aging is something that we all go through. And I would hope if we looked at the world that way, that we could start cracking away at the ageism that surrounds us. And if we all look at ourselves as someone who's aging every day, then maybe we can wrap our arms around the kind of services and supports that we all need to live the choice of life in the communities that we want to. So next slide. This was really pointed out well by Dr. Aronson, but just as a reminder, in California, people are living longer than they ever have before. And 81.9 years of age is the average, which is the second highest in the nation. That's a lot longer than people used to live in previous decades. And as our population is getting older, we need to make sure that we have all the services and supports and policies and funding in place to continue this process that we all are engaged in of aging. Next slide. So the other thing I wanted to say about that is not in a slide per se, but I just wanted to highlight is that not only are we a fastly growing population of older adults, we also are a much more diverse population than we were a decade or more ago. And so we're aging and diverse in our demographics. And we have to pay attention to all of this as we develop programs and policies. In terms of the master plan, this was the timeline that was created. And even though we kind of got, COVID happened in the midst of all of this. So the executive order was passed in June of 2019. The Stakeholder Advisory Committee and some additional subcommittees, there was a research committee, there was a long-term supports and services subcommittee that were all kind of combined to support this work. we started meeting in person, and then in March of 2020, we had to shift to virtual meetings like this one. But I have to say, I have the group of folks in the Stakeholder Advisory Committee and the cabinet folks and the governor's staff and the Department on Aging really made that pivot super easy. And we were able to not only continue to meet in person, but all of the meetings prior to going into COVID, we had started doing some location-based town halls to start pulling information and suggestions from the public. At every step of the stakeholder process and the master plan process, there were opportunities, not just for the stakeholder advisory group to participate, but to gather input from the public, from other organizations, through emails, through attending stakeholder meetings, special town halls, et cetera. So there was a lot of public process. And the goal for the stakeholder group and the Department on Aging was to gather all of the input from all of these places and develop a set of recommendations to present to the governor, who would ultimately develop the master plan on aging that we all are familiar with now. So there were, I think, over 800 recommendations in several categories. Some of those same categories are how we'll break up into groups later. But it was a lot of material to go through, and over 800 individual recommendations. All those recommendations were not reflected in the final master plan that the governor released in January of this year. And some of the categories that the governor's plan created are not identical to the categories of work that the stakeholders and the public comments reflected. But all of that information is part of the archive here. And so just because some recommendations didn't make it into the governor's plan in this first go around, they exist, and they are still goals that some of us individually and through our organizations intend to pursue, and hope that the governor and the administration and the legislature in some cases will also pursue. So they haven't disappeared just because some of the recommendations did not show up in the final plan that the governor released in January. Next slide. So like I said, what the final plan did include is the state's plan, or blueprint, if you will, for the next 10 years, including some immediate steps that are reflected in this year's budget proposal by the governor and the legislature, both administrative changes and additions to staffing and leadership roles within the administration, as well as some very specific legislative efforts, both reflected in terms of policy, but hopefully when we get our final budget signed by the governor, in financial commitment to the recommendations that came out of this. So it's a 10-year plan. Not everything that was recommended is going to happen in the first year, but there are some real bold steps that are going to kick off our work this year and in the 9 years to follow. They also created this local playbook for counties to look at what can each county do to begin to implement some of the recommendations in the master plan, or slightly redesign some of those recommendations to meet the specific needs and concerns of the area that you live in. For example, a priority in some areas might be broadband and digital access because of the lack of connectivity and the lack of stable internet access. And so that might move up higher on a list locally in some places than in others. But every community is going to get the full shopping bag of recommendations, and then figure out how to fine tune those and prioritize those in your own community. And that's what we're going to be doing later today. The data dashboard is this mechanism for us to track progress. Often we set these very lofty goals and implement a policy or create a program or hire a staff person, whatever the resulting implementation plan is, but we haven't really looked at how things change and improve based on these policy and financial decisions that we might make. And this data dashboard has been created to really keep track of the recommendations and what measurable difference can we see from implementing this policy change or investing more money in a particular program, looking at the changes in demographics and the resulting implementation, and how we can really look at progress and not just make lofty claims and hope something happens, but actually hold ourselves accountable for meeting goals that we are setting for ourselves and look at progress. And then finally, as we said before, the local toolkit is going to give us some ability to specifically design goals and priorities and programs that make sense for our community. Next. So some of the issues around COVID that impacted our work as we started as a stakeholder group and as the state was moving forward have created some really important lessons. Some are not new lessons, but we were slow in learning them, but have been problems that have existed for some time. So we definitely had to change the way we do some work and learned some important lessons. For example, a lot of folks who are older are living alone or living and we needed a way to check in with people. And so there was not only local efforts to check in with folks. I know, in Contra Costa, there were exceptional efforts to make sure that people were had access to resources, had answers to questions that they might have. And a lot of that needed to happen on the phone. Now, many of us could have told the administration that phone calls would be useful in this situation, because a lot of older folks haven't, and a lot of younger folks too, don't use the internet or computers as their main source of information or their main source of the main way that they connect with one another. I have two 20-year-olds, and the phone is like a prehistoric entity. They only use it to text and access the internet. They never use it to make a phone call. But for many people who come from an age when the phone was the major tool of getting information and checking in with family and loved ones and getting connected to our medical appointments, the phone is essential. And so that got picked up, and I think the state realized we need to do more than just send information via email and online. So a realization of our needs, but also some of the services that are provided that help people stay in their own homes and communities really needed to be expanded upon during a time of a pandemic, and as a way to keep people living safely and as healthily as possible, if healthily is a word, rather than forcing folks, for example, into institutions where the rise of COVID was much higher, and like Dr. Aronson said, lack of PPE, infection controls, all of which have been a problem for many, many decades, but COVID really added a spotlight to that. So these were the 5 bold goals that the governor released as part of his master plan. And what we're going to be breaking into in a moment are these goals. So goal 1 is housing for all ages and stages. Goal 2 is health reimagined. And goal 3 is inclusion and equity, not isolation. Goal 4 is caregiving that works. And goal 5 is affording aging. These are huge goal areas. And underneath each of them are many specific recommendations. So if you go to the next slide, this is just an example of goal 1, which is housing for all ages and stages. And if you look at, there are many individual recommendations within this goal area. And so this is an opportunity for all of us to just weigh in on what we think needs to be done around housing and how we choose communities, where we age, making sure that they're friendly to an aging and demographic, people with disabilities, that they're dementia friendly, and that they're climate and disaster ready, especially for those of us who live in parts of the state that are vulnerable to hot weather and to fire, etc. Next. So again, these are just more strategies within the goal area of housing that we'll be able to consider when we go into our breakup groups. So the local play, now we're going to talk about getting into those groups. And so the way to implement this, obviously there's things that we need the state to do, to take leadership in. But we also, next slide, need to move into really a lot happens locally. All politics are local is a saying that many of us have heard, but a lot of the implementation and the making these goals a reality are going to happen at the local level. And so this local toolkit was created to help us do that. And today's event is an example of how we take the next step in doing it. So we're engaging our local leaders, next slide, and local organizations, looking at our own demographics, our own data dashboards if we have them, to make sure that we're using the best information in our own communities to set goals and priorities. Next slide. There's lots of leaders and leadership through the AAAs, through lots of organizations, but there's also lots of nonprofit organizations and community leaders and community organizations that need to help inform our work. So all of that needs to be engaged, and lots of you from all these different environments, these different types of networks are on the call today. So we're looking forward to a very fruitful conversation. Next. We can keep going through this. I want to get to the slide to move us into what we need to do. So these are all parts of the playbook that you can look at later that show the different steps in developing a plan. But the most important thing that we do together today is to actually start brainstorming from our experience, our perspective, our knowledge, from wherever we sit, how we would take the first step in implementing some local priorities and some local possibilities. So this is where your work comes in. We're going to be creating a local, a master plan for Contra Costa County. That's the goal. And we're going to have, this isn't going to be an ongoing effort. This is just year one of a 10-year process that, and beyond 10 years, that we're hoping to engage in. There's 5 breakout sessions based on the 5 broad goals that I just described to you from the governor. So housing for all ages and stages, health reimagined, inclusion and equity, not isolation, caregiving that works, and affording aging. Each breakout group will have a local expert and 1 or more master plan and aging stakeholder advisory committee members to help facilitate your session. The goal here is for each of the 5 breakout groups to identify 3 areas to begin working on. And I want to make it clear that, as Debbie said earlier, this is not the be all and end all. Every recommendation that you share is going to be captured. This is just the first 3 priorities that we will start on and build from. So don't, if your suggestion doesn't make the top 3 right now, that doesn't mean that they're gone. In a moment, as you can see from the slide, you're going to get to pick which breakout room you want to be a part of based on those 5 goals. And a screen is going to pop out that's going to list them. And then you are going to click on the one that you want to go to. And you're going to be magically moved into a group with other people who pick that slide with the facilitators that will be helping guide your conversation. It is magic. Zoom is magic. So I'm really hoping that you can all engage in this really important work, really share your ideas and help make this first step for the county a great success by coming up with some first priorities for us to all work on together. So thank you so much for allowing me to participate in this. And now it's time to get to work.
Hey everyone, this is Congressman Mark DeSaulnier, and I've been asked by my friend, Debbie Toth, to give you a few pearls of wisdom and a thank you for what you're doing. I understand you will be watching this video as you come up from breakout sessions on a master plan for aging for Contra Costa County. So for our community, and just want to thank you so much for what you're doing, how important it is. I'm so encouraged and excited that the Biden administration gets it, and we're including this in what is infrastructure, as it should be. Economists say define infrastructure as the support that government provides for productive workforce, and aging and support for our seniors is they continue to live longer lives. They live in dignity. So what you're doing is so important. And infrastructure, the federal government, the state government, local government, nonprofits, all have to be part of that. So I'm just so very grateful for what you're doing. Always want to be able to say thank you to Debbie, a force of nature, and wish you a continued good meeting and continued success on your efforts. It's really important. Thanks so much.
Hi all. So our section was about housing, and the 3 big sort of buckets that we came up with were affordable housing, but not that, frankly, that term almost doesn't mean anything in the context that we're talking about. So really focusing on the extremely low and very low income, because a lot of folks were talking about, there's all this affordable housing, but nobody that they know can really afford it. So making sure that there are targeted units for extremely and very low income. We also talked about the need for a variety of housing types, including boarding care, shared housing, group homes, that especially we had some folks in our group that are working with or living with adults that have developmental disabilities, and a lot of times the sort of affordable housing choices for sort of the general population might not work. And then the last thing we talked about was transportation, and the need sort of that transportation in our community is very fragmented. It can be very complicated to try and figure out how to navigate that system. And in particular, I reported out from the homeless system of care, we're often housing folks in East County because it's more affordable, but that transportation system is very, very fragmented and sometimes not very easy to use. So those were our 3 main themes, and Megan captured that and is going to send it in. Do you want more detail, or is that about what you're looking for?
No, thank you. That's perfect because we are running way behind schedule. So our report outs are going to be top 3 and move on, because Anna's got to elevate the things that we haven't brought up, but everybody's got to hear everything. So next up, Dr. Levin, unmute yourself and tell us your top 3.
Hi. So our top 3, I'll be quick. There were also a lot of other discussions, but building of data infrastructures and information sharing systems through local collaborative initiatives, such as the one that's being started right now with the John Muir Community Foundation and Contra Costa Regional Health Foundation, and trying to expand that such that there's sharing of information between community-based organizations, service providers, and healthcare providers. Number 2 was further development and institution of geriatric training programs and initiatives that include ED certification programs, behavioral health providers, social workers, more geri in our residency programs within the community, and building of interdisciplinary care providers that are also connecting with the community-based service providers. And then 3 was identifying ways to promote care wishes, such as advanced care directives and improving patient palliative access and development of palliative care, availability to promote patient outcomes and support patient and families in their choices and what matters. And then there were some of the other things that came up were access issues and alternate care, innovative care models to provide for access to care.
Thank you, Dr. Levin. All right. Christina, take the mic.
Okay, we had an amazing, oh, can you guys hear me?
Yes.
Okay, for some reason it's saying you can't. All right, we had an amazing group with lots of ideas. It was, I can't wait to give the notes over to Chelsea because there's far more than just our 3 priorities. But one is we need better healthcare options and equity for older adults who have very limited access to geriatric care across Contra Costa County. And we need to make sure that when we create that equity, we don't do it in a way that is based on economic status of the city that you live in within the county. 2, we need a countywide campaign about ageism with collateral materials. We need an ageism and ableism module that is a part of training requirements for county employees. The training needs to be inclusive of technology realities that older adults experience. Internet and technology access is one of the things, but many people have trouble navigating and understanding how to utilize the technology to get their needs met. When we use social media as an example, we need to also put messaging out in other ways so that older adults can also access it. 3rd, we need multi-generational housing that creates inclusion and affordability. We need to have options where granny units and ADUs can be developed and built intentionally with access and space in mind. Cities should work with developers to create small and large homes that allow people with different income levels and access needs to live together in a community. And again, we have others as well, and I'll send those over to Chelsea.
Awesome. Thank you. Dr. Donna, take her away.
Okay. We had 3. This is for the Caregiving That Works initiatives. One was that we wanted a public awareness to help caregivers identify their roles sooner. And so starting at a much younger, in the 20s or so that people really can begin to see that role and understand what it is to be a caregiver, particularly in a positive tone, but just to self-identify. Training and workforce issues with adequate compensation for the paid caregivers, so that we can fill some of the gaps that are there and probably anticipated to be there in the future in areas where we can't even find caregivers who might be able to help an older adult who's living alone. And then the 3rd was and I missed a much better wording than what I'm going to say, which is to have it affordable across the board for caregiving, so that there are affordable services, which would not be necessarily income-based, because many times caregivers need support and help, but it's not, it might be out of their reach because they don't have low enough income. So we want to not penalize, and we want to have more equity for the missing middle. And Lorna, I think we'll be sending that in.
Thank you. All right. Lorna may have already sent it in. We're just waiting on Christina's.
We had a great group for Group 5, Affording Aging. We had a really wide discussion, and some of it really cross-cuts with what it sounds like people talked about in other groups. But the 3 main things we hit on for this report out were increasing access and support, access to and participation in all nutrition programs and affordable meal programs, all the way ranging from improving access to CalFresh and getting more people signed up, to congregate settings, to the cafes, to home delivered meals, and really just improving access throughout Contra Costa County. For housing and homelessness, homelessness was a section of our topic as well. We really wanted to focus on Project Home Key, housing and making sure that the housing is truly accessible for older adults and people with disabilities, and to make sure those room conversions of the hotels especially are really thinking about accessibility for people's needs. And then lastly, really talking about increasing affordability, choice, and transparency for middle income older adults who may not be qualified for Medi-Cal but do not have enough money to fund their own care and living in the community, and just how much people can spend down. And so locally, that really the discussion was also about how to like map and think about gaps that exist right now so that those can be identified and people can work to start to fill those gaps. But we'll send in the rest, and Mariana did a great job getting us all our notes and facilitating that.
Thank you. Wouldn't you hire her as a facilitator? She's amazing. Yeah, love her. So Anna, so your task in the next few minutes, I will say till 11:25 is to sort of talk about what you were seeing in the chat and things that were elevated but didn't make it to a top 3 list, while we pull together mapping out those top 3 priorities with our Advisory Council on Aging work group. So Anna is our brand spanking new program manager of the Area Agency on Aging. Take her away.
Thank you. Thank you so much. What an incredible conversation. Very robust and great priorities that you have put out there. And so just looking at the chat, a few things that I've seen that were put out there. Something about low-income Alzheimer's care. And I think we all know about the affordability issue that's been mentioned many times during this discussion. And there's also the planning ahead, need to have your own voice so that when you get older and you have to make, there's some decisions that need to be made, there's no confusion about what you want. So person-centered planning, person-centered thinking, so that it doesn't conflict with what others want for you is very important. Transportation outside of Richmond, that's also mentioned. Housing, that includes service exchange, and that also brings opportunities for intergenerational housing for people who are looking for housing, as well as able to help an older person or a person with disability with some household needs. And then also meeting the needs of caregivers, not just including the paid caregivers like CNAs. The equity issue, these workers are also going to age, and if they're not making an equitable wage, what's going to happen to them in their old age? And so when we talk about affordability of aging, it's also important to look at our workforce and to make sure that they're also secure as they get older. So those are some of the things that came out of the chat. Anything else that you can think of? I see Pulse as well on the chat. And again, end of life planning. Anything that we missed? Please go ahead and put them on the chat.
So can I put somebody on the spot here as long as we're having this moment? I would like people to put in the chat what they didn't hear that was an important item to them that may have been happening in another room. But Bill Pelter, if you're still on here, and I can't see the whole room because we're spotlighting, but I would ask you to unmute your microphone, Bill, and tell us if you feel like there was something missing around your perspective of the developmental disabilities population in either your group or a different session that you didn't get to go to. So are you able to do that? You have to unmute yourself, Bill, but we've got you on the screen.
I am. Thank you for the opportunity, Debbie. One thing that is a growing issue in the IDD community, which is individuals with intellectual and developmental disabilities, is that as they're aging, of course, their caregivers are aging, which are their families. 3/4 of the adults in Contra Costa with IDD live with their families. And those families, the primary caregivers, are starting to age out of their ability to provide care, many of whom are needing care themselves. And so we are really in an uh-oh moment where do we go from here? And so essentially, one thing that we're trying to think about is looking at what sometimes is called succession planning in the family. Who is going to take over when mom and dad can no longer provide the caregiving? And person-centered planning that Vi mentioned in the chat is so important, where the individual who receives care and those providing care are also involved in that discussion going forward. But point being, the lack of affordable caregiving from professionals coming in to either provide respite or ongoing care for the primary individual with IDD or their family member is a key issue for our community. And it's something that we really have to address. Thank you.
Thank you, Bill. And there are a few more items that came up of the chat, mostly around transportation. Again, affordability of transportation and transportation that actually makes sense because they connect. Balance and fall prevention. Another caregiving conversation. Continue that conversation on caregiving that was held in Contra Costa County. So we'll look into that. Long-term care insurance programs, advanced hair care planning. Again, that was mentioned before. And then workplace employee campaign to educate and incentivize support to hire older persons. That's very important if we're talking about security. Great. End of life planning. Kudos to Bill for making those comments.
So Anna, do you have any thoughts before you close out on sort of what you see? I mean, you're the brand spanking new director of our area agency on aging, who's really going to be lifting and carrying this work. And you're going to be sort of straddling between the Advisory Council on Aging and the work that's happening with the area plan that you have at the area agency on aging, and elevating it to Tracy to do work across divisions. Like, so what do you see in your future in this next year?
This is a great start to our conversation on how to move the master plan forward, because it really gets everybody's voices into the fold, and many of you are have incredible experiences from your different spaces and different work. So this is a great opportunity to gather all of that input and all that feedback. And I can tell you that looking at our area plan and also the state plan, there's a lot of alignment with what we have in our area plan in terms of our goals and objectives that is going to support a lot of the feedback that came out of today. And, some of the, obviously this is a 10-year plan. The first 2 years, we have some incredible, input here that we can, action, we can put into action right away. So I'm very pleased to hear all of this, and we're going to take it on along with all of you. So this is not just the Area Agency on Aging. We have all of you as our partners, and it's really important that we continue to work together on a lot of these projects as we put them out there, and we roll out the different projects that's going to come out of our discussion today. So I'm very happy, and I'm very pleased to see all of this energy around it, and I'm ready to get to work.
Thank you, Anna. And I just want to elevate sort of Ning's comments and Nicole's comments that we really need to bring diversity, equity, and inclusion into all that we do as we move forward on the master plan. Thank you, Anna, for your report out. We're at the very end closing remarks at this point in time. I do want to note that we might not have been able to pull all of this together at the very end here, mapping the three, but I'm going to try and walk through it with you all. I want you to know, I know that chat goes really quick, and so sometimes things get lost flying up in the chat, but we are going to, on our website, have not only all of the recordings of all the sessions that happened in the whole group meeting today, but we're also going to have the event materials, and we're also going to have the top 3 priority areas that emerge for each section, and we're going to be mapping them to the work groups of the Advisory Council on Aging. I mean, this today has been, I don't know about you guys, but every time I hear Dr. Aronson speak, it's mind-blowing for me. So it's been an incredible day. I wanna just sort of walk you through what this looks like. I said a little bit of it before, but we actually have a place in Contra Costa County where the work that we're doing today, the seeds that we created today, are going to be planted, watered, and blossomed. So the areas, the 3 areas on each one of the bold groups are going to come up on the screen as I'm talking. And please know that when we send out that email to you and we post on our website, they're going to actually map to the Advisory Council on Aging work group that they correspond with, where the work is going to be done, and the information for how to access them is going to be there. You're also going to be getting pop-ups during the middle of the rest of this. So please answer those as they come up. So how is this going to work? So let's talk for a minute about who the Advisory Council on Aging is. I keep talking about them. I'm so glad you asked. The ACOA is a group of appointed citizens in Contra Costa who care deeply about our aging population and work as an advisory body to the Board of Supervisors on all things aging in our county, as well as working in partnership with the Area Agency on Aging, Anna's group, on countywide planning, cooperation, and coordination to improve and develop services and opportunities for older residents of this county. The ACOA includes work groups that focus on transportation, health, housing, legislative advocacy, technology, elder abuse, and nutrition. So now you see why we're mapping to those bodies.
Transportation.
So the transportation work group, somebody said transportation, is called SMAC, Senior Mobility Action Council. It is the work group with the coolest name, I have to say. I said Area Agency on Aging as well, and I didn't really describe what that was. They're the state's local designated body to survey aging needs, put together a plan, and use the Older Americans Act funding to execute it through direct service and partnership with a wide variety of nonprofit and community-based service providers, many who are here today. They happen to be housed within Aging and Adult Services, which is in Employment and Human Services, who partners with Health Services and Public Health. So I don't know, are you guys sensing a theme here? There's lots of coordination, collaboration, partnership, planning, policy development, services. Really, all we need is a high enough legislator or policy setter to be on board with us. And wait, that's where we started the day today, with a commitment, right? To help put work that's doable into place in Contra Costa County. And it now has a home for the work and where it's elevated and how we're coordinating across all these different areas. But the thing is that we can create all the structure in the world, but creating structure doesn't create action. You do. So I do hope to see a huge uptick in that participation in those Advisory Council on Aging work groups. In closing, I want to thank the incredible humans who presented today, the brilliant leaders who co-facilitated our breakout sessions in very short time, our new Area Agency on Aging leader who got thrown into this 3 weeks into her new role, our amazing closed captioners who had all kinds of challenges that we didn't expect today, and all of you for showing up. And as you may guess, these events don't birth themselves. I want to thank our planning committee, which includes Shirley Crone, the real Fran Smith, Lorna Van Akron, Jim Donnelly, and Chelsea Velez. And if you ever need someone to help you pull off a really complicated online event and stay cool as a cucumber, you could reach out to the Kalina Institute, who supported all technical aspects of this event. They're super professional, talented, and they're totally committed to our mission. And of course, none of this would be possible without a generous grant from the SCAN Foundation. So please Remember to keep your eyes peeled for an email in the coming days that will provide you with links to the recordings of all the sessions, as well as the polling results from all the polls we've just thrown out to you, and the work group information. So how those priorities are going to land in what work groups, and the contact information to get involved in those work groups. So again, thank you all so very much for coming today, for sharing your ideas, and for continuing to lift this work. I look forward to working with you all. Be safe and have a great rest of your week. Bye.